Ahmed. I'm an anesthesia resident, and I'd like to make these small little videos. This will be episode 1 to help people think through different frameworks in the anesthesia world, the critical care world, things that have helped me over the years to take care of patients and also to take exams. So the first framework that we'll talk about is hypoxia, which is decreased oxygen saturation. This is different than hypoxemia, which is decreased oxygen concentration in the blood. So when I'm called to a patient on the floor who has a decreased oxygen saturation, this is the framework that I think about. You want to have something that's organized so that you can think through the problem very quickly and not to miss any big details. So the big things that I think about are hypoventilation, low FiO2, VQ mismatch, and shunt physiology. So let's talk about hypoventilation first. So hypoventilation is a decreased respiratory rate. The reason why this can cause hypoxia or decreased oxygen saturation is because when the person is breathing at a decreased rate, they have the ability to build up their CO2. When they're not ventilating, they're not able to get this CO2 out of their lungs, which inevitably leads to a low oxygen saturation. We can actually see this quantitatively via the alveolar oxygen equation, which is PaO2 equals FiO2 times the difference between the barometric pressure minus the pressure of water minus PaCO2 over R, where R is 0.08, or 0.8. So if you look at this equation, you see here that this PaCO2 value, as that goes up with hypoventilation, as your carbon dioxide increases with hypoventilation, this overall value for the PaO2 is going to decrease, which shows that as CO2 increase, your alveolar oxygen is going to decrease, which leads to hypoxia. Next on the list is the low FiO2. Using the same equation, we see here FiO2 is being multiplied by this the difference between the atmosphere, the barometric pressure, and the pressure of water. So if you have a low FiO2, this multiplied by this factor right here is going to result in a low alveolar oxygen. Next on the list is VQ mismatch. VQ mismatch is a situation where you are ventilating but not perfusing. So this means that you're able to get air into the airway. So if this is an alveolus, you are able to get air in here. But if this is the vasculature, for some reason, you are not perfusing. So you have some sort of blockage here, like a pulmonary embolus, for example. You're able to get air in, but you're not able to have blood pick up that oxygen. So this results in decreased oxygen in the saturation and will ultimately lead to, or can lead to, hypoxemia. Last on the list is pulmonary shunt. Shunt physiology is the opposite of the VQ mismatch. It's more so of a spectrum, but you can think about it as the opposite. Pulmonary shunting is where you are perfusing but not ventilating. This is a situation where if you have the alveolus again and you have a blood vessel, okay, you are able to get good flow. This flow is great. I'm going to give that a check mark. You're flowing very well in your vessels, but something in the alveolus is causing you to get stuck. For example, here, let's just draw something in this alveolus. Okay, this could be a variety of different things. This could be water, like in the case of pulmonary edema. This could be blood in the case of having some sort of pulmonary contusion or pulmonary hematoma, some sort of bleed, some rupture of a vessel. It could also be a mucus plug. Mucus can be blocking the alveolus, and a big enough plug can actually cause some shifting of your mediastinum. So anything that's getting stuck in this airway is, preventing you from ventilating, but you're able to perfuse because the blood vessels are doing just fine. There's nothing that's blocking the blood vessels, unlike VQ mismatch. So when I'm on the floor and I get called to a patient with hypoxia, the first thing that I look at is the clinical situation. And then if I'm thinking through this framework real quickly, is the patient hypoventilating? Do they have a reason to be hypoventilating? Are they taking high doses of opiates or any medicines that are causing hypoventilation or decreased respiratory rate? Are they protecting their airway first and foremost? So if they're breathing at a regular, normal rate, or they're tachypnic, I know that hypoventilation is not the problem here. So I can automatically rule that out of my framework. Next thing I think about is low FiO2. Are they on room air? If they are, can I just increase the concentration or the fraction of inspired oxygen that they're on? Can I go up to 40%? Can I go up to 50%, 60%, whatever they need? Nasal cannula, non-rebreather, high flow nasal cannula, anything that I can do to increase their FiO2 if they need that. Now, if they have an adequate FiO2, if you increased it to, let's say, 100% and we're still hypoxic. Now I'm kind of thinking about this situation where I'm thinking between VQ mismatch and pulmonary shunt. If I'm thinking about something like VQ mismatch, like a PE, they're otherwise going to be tachycardic. You'll see other signs of pulmonary embolism. For some reason, they have some sort of shunting, a malformation in their vasculature where you're pushing blood from one area to another, and that's going to cause your VQ mismatch. However, this is pretty rare to kind of suddenly happen outside of like a PE, so really what I'm thinking about is like PE when I'm thinking about the VQ mismatch. And lastly, pulmonary shunt, where you're perfusing but you're not ventilating. So does this person have pulmonary edema? Does this person have blood in their airway? Do they have a mucus plug? Or could they have something even like atelectasis, where the entire airway or the alveolus is just kind of broken down or shut down? And the reason why that happens is because either it's positional, they're lying on it, somehow they've been on their backs for a really long time, and a lot of their lung tissue has kind of fallen down. So this is all things that you need to think about. So if the patient's atelectatic, you can sit them up. If they're on the ventilator and intubated, you can give them a recruitment breath to recruit those alveoli. If they have mucus in their lungs and they're on the floor, could you do a bronchoscopy and clear that mucus out? If they have an endotracheal tube, can you suction out those secretions? If it's blood in the airway, do they need to go to the OR to get that removed? Or do you need to do a bronchoscopy and see what you can do to hemolyze or whatever needs to be done? So I think about these things really quickly, and I go through them pretty fast. And by the time that I'm done, I've got a good idea of kind of what's going on, and I don't think I've missed anything. So hopefully this has helped. Let me know if you like this video in the comments below, or if you need a video on something else. All right, appreciate you guys so much, and see you in the next one.